Our next presenter would be Dr. Praful Kumar Maharana.
Thank you, respected judges. So my topic of presentation is correlation of corneal concentration and MIC of antifungals in patients undergoing therapeutic PKP. It's not moving. So why did we go for this study? You know, fungal keratitis is one of the most common cause of corneal opacity in India, accounting for corneal blindness. And the most common cause that have been implicated for poor response to fungal keratitis is poor penetration of drug. However, when we review the literature, all the studies are practically based on experimental studies only. There is no study that directly measures the corneal concentration of drugs in human patients. Similarly, if you go through the result of MUT1 trial, classically it has been proposed that voriconazole penetration is much better than natamycin, but on the contrary, the results suggested natamycin was better than voriconazole. So there was something is lacking with our understanding of this. So this brought us to the purpose of my study. What we did was we measured the corneal concentration of the most commonly two drugs, natamycin and voriconazole, and we compared that with the MIC90. MIC90, you all know the concentration of the drug that inhibits 90% of the test samples. So just to look for whether these drugs are achieving any concentration in the cornea at all. So this study we did at RP Center AIIMS New Delhi in collaboration with our pharmacology and microbiology department. It was a prospective study, and after obtaining the ethical clearance, then we started the study. So we took all patients of fungal keratitis, those were diagnosed based on KOH or fungal culture, undergoing therapeutic penetrating keratoplasty following failure of medical management, and we excluded the other indication of TPK like perforated ulcer, polymicrobial keratitis or impending perforation. Also we excluded those cases which are involving limbus because that would have biased our findings, and systemic diseases where there could be some poor penetration of drug or the immunocompromised status of the drug might have caused the poor response to therapy. So we did what we did, we took the corneal tissue, donor host tissue, we divided that into two parts. One was sent to pharmacology lab for LCMS or liquid chromatography mass spectrometry to measure the concentration of drugs. The other one was subjected to E-strip test. I'll just show you a picture of that. So this is the LCMS setup. This was the E-strip test that we use. As you can see here, there is a zone of inhibition. Okay, so, and this value 0.47, that is what is your MIC90 for that particular drug or natamycin. So statistical analysis, chi-square test for categorical data and Spearman correlation was analyzed to look for correlation data for continuous variable. These are the baseline characteristic of this study. I'm not going to the details of it for the sake of the time. The point is both natamycin and voriconazole group, they were similar in all aspects. Most of the ulcer were moderate to advanced grade, and the depth was almost 60% cases it was crossing mid-stroma, and 30% it was deeper. The mean age was almost 48 years. So this is important for the interpretation of the results. So voriconazole and natamycin, they were administered almost 14 days before I think 2 minutes left, right?
Yes, yes. Yeah.
Okay, so voriconazole and natamycin given for 14 and 17 days respectively, and frequency was 9 and 9. So this was the microbiology. Aspergillus was the most common organism, followed by fusarium. And intracorneal concentration for voriconazole it was 0.08, and natamycin it was 80. And we compared the correlated the various factors like age, gender, duration of treatment, frequency of treatment, time interval from last dose, ulcer area, infiltrate area, ulcer location, and these were the outcome. So except frequency of treatment, none of the factors were influencing the corneal concentration of drugs. For frequency, the more the frequency, the better was the concentration. This was the table of MIC90 and all the individual agents. So I'm not going to into the details of this. This was the summary. So there are a lot of learning points for this summary. As you can see, only in 4.7% cases both drug cross the MIC90. So the thought process that poor response to poor penetration of drug is a major cause of medical management failure holds true as per our study. Intracorneal voriconazole, the only 9% compared to natamycin, where 33% cases they achieve concentration more than MIC90. So the MUT1's finding that natamycin is better than voriconazole still holds true, even if voriconazole claimed to have a better penetration, but natamycin is better. But the scaring part was last 2 points, almost 52 in natamycin and 23 in voriconazole, the MIC was crossing the highest possible limit possible, which probably indicates these organisms probably resistant to the drugs that we were giving. So our study highlighted LCMS can be used to measure corneal concentration of drugs. Second, susceptible to antifungal must be done if your patient is not responding to therapy, and in addition to drug, other factors do also affect your outcome. So the limitation was LCMS. First time we did that, so that was not standardized. With this, I'll conclude here. Thank you very much for your attention.